Good evening, everyone. Can we start? Hello. Hello, everyone. Good evening.
Good evening, madam.
Good evening, madam.
Yes. Are we going to start or you want me to wait for some time?
We can start, madam.
Shall we start then?
Okay, madam.
Okay. This is on your request. I'm doing this. Okay. So it may be the combination of many practical ECGs. Okay. Did you all study about some basics? Huh? I think you all know about the basic ECG. Anyway, we'll just go through. Anyway, I can share the PowerPoint with you all. After that, you all can go through slowly. Yeah?
Okay, madam.
So you know that there's a cardiac conduction system. No? So we usually usually you know the cardiac cycle starts with the SA node, then it goes to the AV node, then the bundle of his, then the Purkinje fibers. Okay. So usually these actually the modified cardiac myocytes that you doing all these things. Okay. So with the what is about the P wave is the depolarization of the atria. Okay, that you saw in the previous one. Initially, that the atria is the depolarization. Okay, it shows with the positive deflection of the presence of P wave. Okay, then after that there's a PR interval, which denotes that the delay of AV node to allow filling of the ventricles. Okay. Then with the QRS is the depolarization of the ventricles. And you know the ST segment is the beginning of the ventricle repolarization. The T is the ventricular repolarization. Okay. So the P, then the QRS, and you will have the kind of a ST segment, then the T waves. Okay. And again, the same thing, because it starts initially with the SA node, then to the AV node, then it goes along the bundle of his. Okay, then the ventricle gets depolarization with its QRS. Then it goes to the ventricular repolar with the ST segment. Once it is complete, then the ST segment comes. And after that, the ventricular repolarization begins at apex, okay, causing the T wave. Yeah, after that, then the ventricular repolarization is complete. So this is this slide shows the time duration of E. The P is the P. Actually, you don't have to look at the mean. The size of the P is again important. The side that you have to look at the P wave is the lead 2. Okay, so you know that when the P is told, there's a right ventricular enlargement. When there's an M pattern, you know there's a left atrial, the right atrial enlargement at all P's, and the M pattern is the left atrial enlargement. Okay, so then the PR interval is a beginning of the P and until it comes to the R. Okay, so that duration is usually 0.12 to 0.2, usually one large square. Remember, it has a one large square. Okay, if it is more than that, this PR is prolonged. Okay, and the QRS is usually the less than 0. Actually, this is actually with 0 point. Okay, not comma 1, 2. that is usually with the 2.5 small squares. Okay, if it is more than that, we call this a QRS is widened. Okay, so that is again important. The duration of the QRS and the PR, all these things are important. And the ST segment is again, sometime you can see in certain situation that is important, ST depression and things that we'll discuss, usually the ischemia, and also that the QT, you have heard about the QT prolongation. Okay, so prolonged QT is again important because the prolonged QT is important when it's sometimes it can lead to for the ventricular tachycardia. So because of that, it's a prolonged QT is important. And the T waves again is important, and all the presence of U wave is U is here after the T, that you sometimes usually you get the presence of U when there's a hypokalemia. Okay, so the other thing is the Q is the first negative deflection, and the R is the first positive deflection, and S is the second negative deflection. Okay, so what else? These are the important things: the P, QRS, and the T, and the PR, as well as the QT width, and also the QT, QRS width, as well as the QT duration. And this actually does the same thing as the previous, but when you get the ECG strip, that you have a large squares as well as a small squares. Okay, one small square is a 0.04 seconds, and one large square is a 0.2. I told you the PR interval is a one large square. Less than one large square is usually 0.2 seconds. Then less than should be 0.2 seconds maximum. So actually this side is for the voltage. Usually then we call it 1 millimeter, 2 millivolts, that height. Okay. So that is again important when we are talking about the height of the anything. Okay. So then we call it one small square height is actually one. That is again that we discuss about when they are a myocardial infarction, anything that we talk about the height of the ST segment also. And this is to show just where you keep your ECG leads, that that there are actually limb leads as well as the chest leads. Actually, we put limb leads into usually the right arm, is the right forearm or wrist. Okay, usually it's a wrist that we apply, and the LA is the left, left wrist, and the LL is the left lower leg, and the RL is the right lower leg. And usually we keep it at the ankle. Okay, and the chest leads, there are 6 chest leads, and the chest leads that you keep in the first V1 that you keep in the 4th intercostal space on the right side, right sternal edge, and the V2 you keep it in the left side, the same level. And the V3, V4 that you keep in the midway between V4 that you keep in the 5th intercostal space in the mid clavicular line. Okay, that V3 you keep in between these two. Okay, and the V4 is the anterior axillary line, that the same level as the V4, and the V6 is the mid axillary line. And this is to show actually where you actually see your leads. V1 to V6 is usually, that's how you, this actually looking at how it looking at the heart. usually you can see when it is goes toward the V1 to V6, that it's there's a positive deflection that is gradually increases. You can see this even these arrows are getting taller and taller. Okay, so usually in the V1 very small R, but when it goes towards the V2, V3, V4, V5, V6, V6 is the usually tallest R. Okay, that is in the usually normal person. And these are actually the limb leads, because again there are 6 limb leads. Okay, so the AVR, AVL, and the AVF, and usually you can see that AVR is actually going away from the heart. Because of that, you usually see in the normal person the negative deflection in the AVR. And these are looking at the heart, no? So because of that, AVL and the 1 are actually getting the positive. Okay, and so remember those things, because sometimes it's when the right ventricle enlargement is there, you get the more positive things in towards this way. When there's a left ventricle enlargement, and the positive things are towards this way. I think you all have to read this more, okay, because I cannot tell everything. So this is the normal ECGs. Actually, when you are reading a ECG, that you read along first, actually you are looking at the first the P wave, then the QRS, then the T. Okay, so first thing that you have to see whether the patient is in sinus rhythm or not. If the P waves are there and the QRS, T are the things are there, you know that the patient is in sinus rhythm. If the P's are not there, that the P, so other things, other things are not there, you know the patient is not in the sinus rhythm. That is the first thing that you have to see after taking an ECG. Then of course that you have to look at the each lead, and also the P, Q, R, S, T, that you have to see whether there are any abnormalities. Okay, so these leads are usually leads actually 1, then the 2, then you can see 3. You can see the 1 is the towards the positive thing. You can see that there's a positive deflection. 2 is not that much. 3 is again the more or less in the same way. But you can see the AVR is a negative. Usually you see in the AVR all the things are negative. Okay, P negative, and also you will see the R, so that is also negative, and the T's are also getting negative. So the usually AVR lead is you see everything is a negative. Whereas in the AVL lead, all the things are in the positive. So sometimes the people actually they put the limb leads in the wrong way. To the right side, they put the left lead. So what will happen? In usually that situation, you will see the positive thing in the AVR and the negative thing is the AVL. So sometimes actually there are people that the OPD, they used to send the saying that patients are getting admitted because of this wrong limb lead placement. Okay, because of that abnormal ECG leads, ECG findings, patients are getting admitted. Actually, when you repeat the ECG with the correct limb placement, then the ECG will be normal. So always see whether when you get a normal patients, asymptomatic patients whose ECG, you have to see whether the AVR and the AVL also, because if it is positive here, either it's wrong limb placement. Other thing is it could be something like dextrocardia. Okay, because in the dextrocardia you will get the heart on the right side. In that situation, you will see the positive thing in the AVR. Okay, in that situation, you will not see the I told you towards the V1 to VC, the gradually R wave getting the height will be increased. Now you can see the R is very small here, then it is somewhat here. It's little taller than the V2, then the more taller than the V4, V5, and V6. Okay. So in the dextrocardia said that you will not see that. There will actually poor R wave progression towards the V1 to V6. If that is there with the positive R in the AVL and the negative R in the AVL, that you can say dextrocardia. Otherwise, wrong limb placement, that what you see is the only the positive R in the AVR and the negative in the AVL, and usually the V1 to V6 is normal pattern. Okay, so in that situation, you have to suspect wrong limb placement. Did you all get it?
Yes, madam.
That is again somewhat that I want to learn. Okay, so you should know what is the normal ECG pattern. Okay, so this is the normal ECG. You can see the P height and the QR, and also this is the calibration. Also, you have to look at if the calibration is somewhat tall, like somewhat height is somewhat here, and you will get the small complexes. That is not actually that you should not diagnose small ECG complexes and diagnose query pericardial effusion, but you have to see the normal calibration also. So how do you calculate the heart rate? That of course you all know very well, because you have to actually you have to count the number of large squares in between the RR. Okay, so usually you can see there are almost 1, 2, 3. So usually the number of 300 is divided by number of large squares. Then you can get the heart rate when it is regular. Okay, when it is irregular, there's another mechanism, and which I'm not going to discuss today. That you all can read it. And this is about when there are small squares, but it's difficult to count the small squares. So you don't have to do it. You can actually count the number of large squares in between the RR interval, and you divide it 300 divided by, if there are 4, that you can divide it by 4, then the rate will come as 75. So what's the heart rate of this? You can count 1, 2, 3, 4, 5, 6. Okay, so you divide 300 by 6, then you get the heart rate as 50. Like that, you can count. When it is a regular rhythm, you can count by that rate. So this is the, as you can see, number of, depending on the number of big boxes, the rate is, if it is 1, 300, 250, like that, you can gradually, when you are get experience, that you can, without even counting, you can say what's the heart rate of that ECG. So this is actually the sinus rhythm that we'll discuss some ECGs now. You know, the sinus is the U, P, Q, R, rest, as also the T is there. This getting the repeat, same thing. Okay, so usually the PR interval is less than 0.2 and the QRS is less than 0.12. Okay, the heart rate usually 60 to 100. Okay, that is your usually the sinus rhythm with a normal heart rate. This is the sinus bradycardia. When the heart rate is less than 60, that you call it sinus bradycardia. What are the causes of sinus bradycardia? Tell me some few causes.
6 sinus syndrome.
Yeah, one thing is 6 sinus syndrome. Okay.
Physiology in an athlete, madam?
Yeah, very good. Physiology. It could be in the athletes. Hypothyroidism, yes. What else?
Beta blockers.
Yeah, if the patient is on any rate limiting drugs, it could be beta blockers, it could be drugs like verapamil, or it could be drugs like diltiazem, actually can cause bradycardia. What else?
Raised intracranial pressure, madam.
Even raised intracranial pressure, it can cause bradycardia. Okay, so these are the common thing. And the sinus tachycardia is when the heart rate is more than 100, and you call it sinus tachycardia. Why it is sinus? You get the P, QRS, and the T pattern is there. Okay, so and the rate is more than 100, but the usually PR and the QRS with this maintaining. Okay, so some causes of sinus tachycardia.
Anemia,
Anemia, yes.
hyperthyroidism,
Hyperthyroidism,
Right coronary artery thrombosis.
right coronary artery thrombosis. Usually you get the bradycardia. Usually what you get is brady, right? Because there's a C node and they will not supply some time can be disrupted, no? So anything else?
Anxiety,
Anxiety, very good.
fever,
Fever, yes.
use of
Yeah, beta agonist drugs like which can increases the heart rate.
caffeine,
Caffeine, yes.
alcohol,
Alcohol, yeah. But the patient's going into shock. Again, that you get the physiologically, the heart rate is increased. No? Those are the actually situation that you will come across when the tachycardia, and also the patient who is going to the heart failure. Okay, those are actually physiological mechanism to maintain the cardiac output. And what do you mean by sinus arrhythmia? Anyone?
It's the physiological thing, madam, that happens with respiration.
Yeah, it's a physiological thing happens in respiration in the deep. What happens in the respiration?
During inspiration, the rate increases, and expiration, it decreases.
Yeah. That shows here as well. Inspiration rate is here, and the expiration rate gets low. And it's very common in young children and the adolescents, and also in certain categories of people in old age. Who are they? And diabetics is there, and they're going into the autonomic neuropathy, again that you see the sinus arrhythmia. Okay, remember that. And otherwise it's very innocent one. You don't have to worry if you see a ECG like this. Okay, so if you want to confirm it again, that you can ask they are to repeat the ECG with the usually the lead 2 with a deep expiration. Okay, you can ask this technician to repeat the ECG if you are not very sure about the ECG. You don't have to do anything if you see this. So this is about the premature atrial contraction, what you call is usually atrial ectopics. Okay. So these are actually, you will get the morphologically the same as the normal QRS. But what is abnormal is the P wave. Okay, so if you see this here, that you will see that the P is getting somewhat abnormal, not the usual normal P here. And this is get abnormal. After that, there is a pause. But the morphologically, QRS is same as the narrow complex. So because of this atrial, but the morphological, there is a little difference in the P wave. Okay, after that, there is a little pause. These are the actually atrial ectopics. Okay, the P wave is premature and abnormal as well. Okay, and otherwise it's usually This could be again there could be several reasons for this. Could be even the ischemia. If patients may be getting a problem in the SA node. Okay, so in that situation you have to be careful. Even the patients, so it could be drugs as well. So you have to keep an eye on these patients whether they might go into sometimes the atrial other tachyarrhythmias as well if you do not be careful. Okay, so that's again important thing. So now actually we'll discuss about the cardiac arrhythmias and you call it what is arrhythmia when there's abnormality in the cardiac rhythm. It's called arrhythmias. It's usually when there's arrhythmias, if it is significant that the patient will actually they can go into sudden cardiac death. So if they are not going into cardiac death, they will get the syncope, pre-syncope. They can go into the heart failure, the symptoms like palpitations. Those are the important things that you have to see in the history. So if the patient is comes to syncope, that you have to suspect that this could be cardiac arrhythmia. Okay, even the patients who are in this 6-sign syndrome, they can come with the syncope or dizziness. Or patients who are getting the frequent ectopics or going into some arrhythmia, they can get palpitations as well. So all of a sudden, this when it is severe, they can go into the sudden cardiac deaths as well. So probably patients who can get the VT, ventricular tachycardia, can go into the sudden cardiac death. So the arrhythmias again 2 types. It could be bradyarrhythmias or it could be tachyarrhythmias. This is actually some flow chart for you all to I made it make it simple just to learn. It's a tachyarrhythmias and the bradyarrhythmias. So under tachyarrhythmias that you get is 2 types. Either it's a narrow complex tachycardia or broad complex tachycardia. Okay, so the narrow complex tachycardia is divided again into the regular narrow complex. What do you mean by narrow complex? Narrow complex is actually QRS width. I told you QRS width is usually less than 2.5 small squares or 0.12, less than 0.12. If it is less than that, you call it a narrow complex. But if it is more than that, if the small squares is more than 2.5, then you call it a broad complex. Okay. So this narrow complex or broad complex depend on the QRS width. So narrow complex or broad complex is again divided into the regular narrow complex, irregular narrow complex, or regular broad complex, irregular broad complex. What are the regular narrow complex tachycardia? That is supraventricular tachycardia. There are again 2 types that you know, the AV nodal reentrant tachycardia, AV retrograde tachycardia, like there are several types in these are supraventricular. Because of the supraventricular, they are narrow complex. Okay, so you all just keep it in as the supraventricular tachycardia. So, okay, remember then the narrow complex irregular tachycardia as the atrial fibrillation. Okay, this is again supraventricular, but we categorize them in a separate way as it is irregular. Okay, and also the management is different, these 2. And the atrial fibrillation and also atrial flutter. It is not atrial fibrillation. This is atrial flutter with a variable block, again irregular. Okay, I will show these ECGs. So again, narrow complex, regular, narrow complex, irregular. Under narrow complex, regular, what you see is the supraventricular tachycardia, and the narrow complex, irregular, atrial fibrillation or atrial flutter with a variable block. Okay. Now this is a broad complex. Broad complex regular tachycardia is a ventricular tachycardia. Okay, and the irregular one is a broad complex irregular, univentricular fibrillation. And also sometimes when there's a patient with bundle branch block, either it's a left bundle branch block or right bundle branch block, when it is combined with atrial fibrillation, that you will see it's a broad complex, again irregular because it has the atrial fibrillation component as well. So you might see something like that as well. But remember, this patient is in a patient who is having the cardiac arrest definitely. Otherwise, you won't see ventricular fibrillation in other normal patients. Okay, so you cannot diagnose a ventricular fibrillation in a conscious patient. Remember. And in that situation, you have to suspect something like atrial fibrillation in the bundle branch block. Okay. Now we'll discuss the individual ECGs. So this is the SVT, narrow complex regular tachycardia. What is regular means the RR interval is a regular. Okay, you can see if you are not sure, you can take a piece of paper. You can see whether whether each R is falling at the regular pattern. Okay. And usually the P waves you don't see. Usually somewhere that they will embedded in this somewhere here. Okay. Because of that you don't see it. So you don't call this as a sinus tachy because you can't see the P waves. Okay. When the P waves are not there, when the rate is very high, that is definitely above 150. So in that situation, that you can say this patient is having supraventricular tachycardia. Have you all seen ECG with supraventricular tachycardia? Yes or no? Anyone? නැත්තම් නෑ කියන්න.
No, madam.
Even during the appointments, you all didn't see, no? Medical appointments? I don't think we had one recently. About a month ago, I can remember there was one patient with the diagnosed supraventricular tachycardia that she has come with another acute attack. So there are actually the patients who are actually because of that the problem with the say note, they can actually they can get the episodes of supraventricular tachycardia. Okay. So how do you manage these patients? So if you see this kind of a ECG, it's a regular and the narrow complex. It's a narrow, no? You can see, this QRS is less than 2 and only 1 is here. So how do you manage these patients? Anyone?
Madam, we can block the AV node.
How do you block the AV node?
Drugs like adenosine.
Yeah, it depends on the patients whether they are hemodynamically stable or not. Okay. What do you mean by a stable patient and what do you mean by unstable patient? If the blood pressure is normal, that you can say the patient is hemodynamically stable. Okay. And if the blood pressure is low, the patient is unstable hemodynamically. So your management is depends on whether the patient is stable or not. For an unstable patient, there's no time for you to give drugs and wait. In that situation, you have to give you cannot give the DC. You have to do the cardioversion, okay? Electrical cardioversion. So that situation, you have to give the shock that you start with in the supraventricular tachycardia, you give it a low energy source. Usually you can start with a 50 joules. Then if this patient is not improving, you can go to the 100. Like if it is not improving with that also, you can go like to the 200. Like that, you can gradually increase. If the patient is stable, what do you do? Now they are hemodynamically stable. The blood pressure is normal. They are conscious. and they are not having any heart failure, or their patients is stable. As you said, we can give drugs like adenosine. Adenosine is a drug of choice to give for the supraventricular tachycardia. How do you give adenosine?
IV bolus.
Yeah, you have to give the quick bolus. Okay, so you have to give within seconds. Okay, so usually you have to, once you give it, you have to flush it at the distilled water or normal saline. Okay, otherwise it won't reach the heart. You have to quickly flush it with the again with the normal saline, no distilled water. And so usually you can give the you had to contraindications to give adenosine is the what is the contraindication? Bronchial asthma. Okay. So you have to exclude the bronchial asthma. If it is not there, you can give, it's a very safe drug otherwise. You can start the 6 milligram, then you can repeat it again. If you are not improving, you can increase the dose to 9, then 12, like that you can see. Okay, you can try it. What are the other medications that you can give other than if the adenosine is not available?
Amiodarone.
Amiodarone also you can give, but other drugs for the supraventricular tachycardia, you can give verapamil. Okay, and also you can give sometimes beta blockers as well, IV preparations. Okay, so verapamil IV or beta blocker IV beta blockers. Okay, so for us, IV beta blockers are not available. Other countries, they have metoprolol, they have esmolol. Okay, so but we don't have those things. But we have IV verapamil. So if the adenosine is not available, if blood pressure is normal, that you can give IV verapamil also. You can start with a small dose that you can repeat it. You can give 2.5. After that, if not to improve, you can give to 5. Like you can see the patient's response. Sometimes some patients we do the what do you call that? Carotid massage. Okay. So what are the have you seen the carotid massage? Those are the vagal maneuvers. Okay. So other than carotid massage, there are other Valsalvas and also the eyeball pressure, the immersion of eyes in the cold water. Those are not practical, but the carotid massage you can do. But before applying for the massage the carotid, you have to exclude the presence of any carotid bruise. Because if there's a carotid bruise, that means there's a underlying atherosclerosis. So you might dislodge carotid plaque with the massage. So make sure that there are no carotid bruise before you do the carotid massage. That is again you can do in a young patient or even other patients. You can try it. Some patients actually they revert even with the carotid massage. Okay. So the failing carotid massage, you can go for drugs. So when the drugs are failed again, that you can go for the cardioversion. Okay, that is about the supraventricular tachycardias. Then the narrow, this is not very clear, but I think you can see. This is the narrow complex irregular tachycardia, that is atrial fibrillation. So what are the features of atrial fibrillation in the ECG? How do you diagnose atrial fibrillation? Who knows features? I think I have told about the previous group. If anyone is in there in the previous group can tell about those features. I have told you all about 4 features, how to diagnose atrial fibrillation in ECG. Anyone? Yeah, one thing is the fibrillatory waves. So what's the best site for you to see the fibrillatory waves? Usually the V1, okay? Right? You can see the fibrillatory waves very well in the V1. Okay, and what else? You can see the even in the ECG, there are vibratory waves. Other features? Yeah, the RR interval is irregular. You can see that the R to this R from this to this is 1, and again they vary. Okay, so the RR interval is irregular. The small complexes, narrow complexes, RR interval is regular, and there are no P waves. Okay, and there are vibratory waves. And what is the fourth feature? And the height of the R also will vary. Okay, you can see this is taller and this is shorter. Okay, so you can see that because the volume also will vary with the atrial fibrillation. So because of that, height of the R also will vary. So what are the features? 4 features: absent P waves, and RR interval is irregular, and there are vibratory waves, and also the height of the R also will vary. These are the 4 features that you have to comment on when you are talking about the ECG, atrial fibrillation ECG. Okay. So how do you manage the patient with atrial fibrillation if they come with acute atrial fibrillation? So some patients are acute, some are chronic, no, in the atrial fibrillation. Because you see the chronic atrial fibrillation also, there are several causes. Okay. So I'm not going to discuss all these things. You must read. So if a patient comes with acute atrial fibrillation, that means patient's rate is very rapid. Okay. How do you manage?
Cardio
Again, the same principle, whether they are hemodynamically stable or unstable. Okay. So if they are hemodynamically unstable, that you have to do the electrical cardioversion. And if they are stable, you can treat with the IV medications. But remember that not like the supraventricular tachycardia, atrial fibrillation. What's the problem with the atrial fibrillation? Thromboembolism. Okay. So if it is a chronic case, there may be underlying atrial thrombi, intracardiac thrombi. So when you do the cardioversion, this can get embolization and patient might end up with a stroke. So because of that, you have to be very careful. The other countries, what do they? They do the echocardiogram urgently, and they exclude the intracardiac thrombi before doing the cardioversion. To be on the safe side, as we have known, if you know that the patient is not on any anticoagulation, so if the patient is on anticoagulation, you don't have to worry because there's a medications are given to prevent the thromboembolism. No? So in that situation, you can do the cardioversion safely. Otherwise, in those patients, we start heparin. We start the heparin, under heparin cover that we give the cardioversion. Again, that you start with if there's the electrical cardioversion, you start with the smaller energy source, then you can gradually increase if the patient is not improving. Patients who are hemodynamically stable, if they are not in shock or if they are not in heart failure, that you can use the medications. What are the medications that you can give for a atrial fibrillation? Just to the rate control. Anyone? Yeah, you can give a beta blocker. It's very good. You can give beta blockers to control the rate. What else?
Calcium channel.
Yeah, you can give even the verapamil. Oh, yes.
Amiodarone?
Yeah, amiodarone is a drug. Actually, you can give to the rate control as well as the rhythm control. Okay. So, because atrial fibrillation both are important, the rate control as well as the rhythm control. So, preference is now go for some drug like amiodarone. Means practically that we go for that. But remember, if the patient's blood pressure is low, that you cannot give amiodarone because there's tendency for blood pressure low. In that situation, if they are not blood pressure is marginal, if we want to give a medication, that we give IV digoxin. Okay. to control the rate. And later on that you can start, if the blood pressure is all right, you can give the amiodarone bolus. When you are giving a bolus amiodarone, that you don't give it quickly like in adenosine, okay? So here that you give it very slowly, over 20 minutes like that you give a slow amiodarone, and after that you give a infusion to go for over 24 hours, okay? So as a maintenance dose. So if the patient is on that, we started the heparin also on the situation that you have to find out what is the etiology for the atrial fibrillation, and you have to correct it. Sometimes it could be ischemia, so you have to correct the underlying ischemic heart disease. If it is due to heart failure, you have to treat the heart failure. If it is thyrotoxicosis, you have to treat the thyrotoxicosis. If it is hypertension, like there are so many causes. Okay, so you have to important things. You have to correct the underlying etiology as well. And also, if it is chronic, for us, chronic is usually patients who have in underlying structural cardiac lesions, like in mitral stenosis, or even with other structural cardiac lesions they can get. Those situations, actually, the atrial fibrillation is permanent and persistent, okay, because of the underlying structure. Since whatever the things that we try to get them into the sinus rhythm, it's difficult. So in that situation, patient has to be on a rate control drug, as well as the drugs to prevent thromboembolism, that anticoagulation. Okay, the warfarin, no. Usually what the available drug for us is warfarin, no. So otherwise, the newer anticoagulants also they are in the other countries. So that is about the atrial fibrillation. Remember, that is a very common thing. I think probably you all have seen the atrial fibrillation ECGs. If not, see some in the web as well. So atrial flutter is another one, probably that you all have seen it in during your other physiology appointment. The rate, again, this is a rapid rate in the when they come with the acute ECG, that you see the, how do you diagnose it? You see it's as a sawtooth pattern. So very easy to diagnose. So sometimes when you see the rate is very rapid, it's difficult to see whether it's a flutter or not. But the something like this is there. These are actually the flutter waves. So when you give a medication or even the vagal stimulations, you see the underlying pattern. Then you see flutter waves very well. Okay. Sometimes rate is very rapid. Okay. So this is 200 like no. So in that situation, it's very difficult to diagnose flutter. But you have to, if the patient comes with this type of a rate, if you suspect it, you have to definitely control the rate, ventricular rate, and then you can see the underlying rhythm. What is the pattern like? So, this is about this is again the flutter waves are there. Actually, you can see the rapid heart rate. So because it's difficult to see, okay, but the patient has underlying some ischemia as well. Because of that, patient has got a flutter. And this is actually when there's a flutter, could be regular, or sometimes flutter could be irregular as well. So in the if there's a flutter with a regular, that you see is a flutter regular. Okay, when the rhythm is your regular and the pulse also regular. But when it is a flutter associated with a variable block, that you see the RR interval is irregular. So how do you differentiate from the atrial fibrillation? Here that you see the sawtooth appearance in between. So these are not fibrillatory waves, but these are flutter waves. Okay. Management is more or less same. So that is all about there are other ECGs as well, the multifocal atrial tachycardias, wandering pacemakers. Those ECGs actually I could not add actually, but try to see those ECGs as well. Okay, wandering pacemaker is one thing, and also the multifocal atrial tachycardias. So can you all write them down and see those ECGs? Okay. And now we'll move to the ventricular rhythms. So like the atrial ectopics, that you can see the ventricular ectopics as well. These are actually the broad complex. You can see, this is the QRS with this broad. Those are not narrow. So these are actually ventricular premature beats, and we call this a ventricular ectopics. Ventricular ectopics could be sometimes occasional. When it is every other beat, then you call it a ventricular bigeminy. Okay, when it is frequently more that you get, you will call this. Suppose that you get the same QR ventricular pattern frequently there are in few leads, then you call this a non-sustained VT. Okay, when there are few like this comes, and when there are frequent things, again, this could be again the cause could be again there's a ischemia, or again it could be the drugs or electrolyte imbalances. Okay, there are many causes for the ventricular ectopics, but in a healthy patients also, this is a very innocent thing. You can see if the patient is asymptomatic, if they are all right. The occasional ventricular ectopics, you don't have to worry. But if there are frequent ventricular ectopics, definitely it has to be evaluated. If there is something like ventricular bigeminy, bigeminy is every other beat that you get. So this is about the ventricular tachycardia. Ventricular tachycardia, again, that there are actually no, you don't see that this is not definitely sinus now, and also you get the broad complex, and you don't see actually the typical piece, and but there are actually there are many actually features of the ventricular tachycardia for you to diagnose, and the fusion beats is something that you can see because it's a fused with the P waves as well. Okay, it's a normal QRS is fused with the normal sinus one. So then it is called the fusion beats. And we'll see whether I have included another ECG for ventricular tachycardia. Not like so. So ventricular fibrillation. So how do you manage the patient with ventricular tachycardia? So there's a broad complex regular tachycardia. So if you see a broad complex tachycardia, what are the causes usually? Anyone, quickly, don't waste time. ළමයි නිදිද?
Acute MI.
Yeah, acute MI, yes, very good. Acute MI, yes. That's actually the commonest cause, okay? So sometimes the cardiomyopathies, okay? So those kind of patients also can go into, they can develop ventricular tachycardias. And so how do you manage? If you see a ventricular tachycardia?
DC cardioversion.
So it depends on the patients who are the cardiac arrest patient that you can see a ventricular tachycardia. In that situation, if the patient is in a cardiac arrest, that you have to do the DC cardioversion. Okay. So otherwise, if the patient is clinically well and you are getting the ventricular tachycardia, in that situation that you can treat with the medications. So what's the drug of choice that you give in the ventricular tachycardia?
IV lignocaine.
IV lignocaine is one drug that you can give. Yes. Another one? Drug of choice? Amiodarone. Yes. Amiodarone is a drug that you can give irrespective of what's the underlying heart is, because a lignocaine is you cannot start if the patient is in the heart failure. So underlying structural cardiac disease is there. Lignocaine is not a very good drug. Otherwise, you can use the lignocaine. But the tendency for now to go for a amiodarone bed because very safe, and you can use it whether it's a normal heart or whether it's a structurally diseased heart as well. So like in the bolus and followed by the infusion. So if the patient is in the cardiac arrest or hemodynamically unstable with a heart failure or low blood pressure, that you had to do the DC cardioversion. Ventricular fibrillation, that you see is something bizarre, broad complex, irregular tachycardia. What's the management?
Defibrillation. Defibrillation should be done.
Yeah. Why? Can you give drug medications? What's the place for medication here if you see a ventricular fibrillation?
Adrenaline.
Yeah, in a way, you are talking about adrenaline when the patient is in the cardiac arrest. No?
Yes, ma'am.
Definitely, if you see the ventricular fibrillation, the patient is in cardiac arrest. You cannot see the conscious patient with the ventricular fibrillation. Remember, it's a patient in a cardiac arrest, so you have to do the cardioversion. Okay, adrenaline is a part of the management of the CPR. Otherwise, if you see the ventricular fibrillation, you have to do the cardioversion until it's come to the normal rhythm, sinus rhythm. Okay, no other options, just the cardioversion. So torsade point is, I think you all have seen ECG. There are several causes. It could be the congenital or electrical disorders like hypokalemia, hypomagnesemia, hypocalcemia, tricyclic antidepressants, and other anti-arrhythmic drugs. Okay, so in that situation, how do you see the ECG? That you see something like this, because that's you can see the changing of the pattern as well. Okay, the twisting of the actually electrical activity, you can see something like that. This patient who is at the prolonged QT. Okay, so the prolonged QT, now they are going to the torsade dyspontins that they can actually, you have to it's a medical emergency again. So then we have completed the tachyarrhythmias. We have discussed about the narrow complex regular tachycardia, the SVTs, and the narrow complex irregular atrial fibrillation, flutter with a variable block, and the broad complex regular is a ventricular tachycardia, and the broad complex irregular is a ventricular fibrillation. Okay, so now we'll move to the bradyarrhythmias. There are 3 types, first degree heart block, and the second degree, and the third degree. Second degree again divided into the Morbis type 1, that's a Venki back, and the Morbis type 2, and those are the second degree AV block. And the first degree heart block is it's actually very innocent one. It's just a prolongation of the PR interval that you see in this is condition with the acute rheumatic fever, diphtheria, and the myocardial infarction, and the drugs as well, the rate limiting drugs, and also digoxin, so even the carnero poisoning that you see first degree heart blocks, or sometimes the canori that you might not see the P's at all. Okay, it could be they can get the nodal rhythm. So nodal means there are no P waves. Okay, or the P's could be abnormal as well. And so this is the first degree heart block. How do you diagnose? What's the normal PR interval?
One large scan.
One large score. So if it is more than, you can see, one large score from here to here. So it is beginning of the P to here, more than one large square. So it's a first degree heart block. So usually you don't have to do anything. You can wait and see if they are offending medications like rate limiting drugs. You can stop it. Or if there's this Kaneru, again, that you can observe and see. So the type 2, the second degree heart blocks, there are again 2 types. And the Morbis type, just ignore this type 2 one. The second degree heart block, and the Morbis type 1 is the Venki bag, because Venki bag that the PR interval is getting prolonged, and after that there's an omission of 1 QRS. Okay. So when it is isolated, usually it's physiological and due to increased vagal tone, and it could be abolished by exercise or in atropine. Okay. But Nobis type 2 is conditions like the 2 to 1, 3 to 1, 4 to 1, like those are actually, I will show the ECGs, and these are actually not innocent. Okay. So you have to do the pacemakers, you have to put a pacemaker if you see this thing, if the patient is not improving. So this is the Venki bank ECG. You can see that this is the prolonged, PR is getting prolonged, and after that there's a drop. Again, you can see the PR interval is somewhat, this is getting prolonged, and there's again the drop of a QRS. Like that, this is the Venki back. And this is the Morbis type 2. And these are actually that you will see with the 2, it could be 2 to 1 block or 3 to 1 block, because 1 P, then the QRS is there, and after the second P, there's a drop of QRS. Then for 2, 1 is dropped. You call it a 2 to 1 block. If there's a 3, for 3 P, sorry, if there are 3 P's are there, then you call it a 3 to 1 block, and after that there's a drop. And if there's a 4 P's are there, then you call it a 4 to 1 block. Okay, so that those are again the you have to do something. You have to do the pacing if you see this kind of a ECG. So the complete heart block again is important. There are again several causes. Again, it could be the coronary heart disease. Usually when there's a right coronary artery disease, it supplies the AV node, and so, and also sometimes it could be the left dominant as well. But the ischemia is causing to the ischemic to the AV node, that you can get the complete heart block, or it comes other causes like sarcoidosis. It could be congenital as well. Remember the complete heart block, congenital as well. How do you diagnose usually? That P's and QRS, there's no association between each other. So P's has its own rate and the QRS has its own rate. Okay, there's complete dissociation. So that's how you diagnose, and usually there's a bradycardia as well. So usually that you have to see, you can see the QR is RR interval is regular, but PISA there, but there's no association between the some PISA, one P here, one P here, one is here. There's no association between the P and the QRS. Okay, so you can see the PR is one is duration is here, somewhat here, and there's a more prolonged, and this is another shorter. Like there's another P here, so there's no association at all. So that's a complete heart block again, depending on the underlying cause that you have to treat. If it is ischemia, that you had acute coronary syndrome, that you have to correct acute coronary syndrome, but you have to bridge until it's getting cured with a temporary pacemaker. Okay, so if the blood pressure is coming down, you have to put the pacemaker. If the patient is symptomatic, yes, patient need the pacemaker. If sometimes it's a congenital complete heart block, patients are asymptomatic, they are all right. So there's no urgency, and you can observe those patients. If they are getting symptoms only, they need pacemakers. Otherwise, not routinely. There's a condition called WPW syndrome because it's an abnormal band of atrial tissue is there connecting to the atria into the ventricle. So it bypasses the normal pathway, and because of that, there's a they can get the paroxysmal of tachycardia. Sometimes they can go into the atrial fibrillation, and also they can sometimes can go into the if you use the incorrect medications, they can go into even the ventricular tachycardia. So if the patient comes with a previously not a known patient with atrial fibrillation, if they, for example, if the patient without any reason, there's no ischemia, there's no underlying cause as well for you to think this is the etiology, and that situation that it could the patient may be having WPW syndrome. Okay, that situation you have to be very careful because a certain medication that you can give, because the digoxin and the verapamil are drugs that we give for atrial fibrillation. So if you use these medications, actually these patients can go into the ventricular tachycardia, remember. So in the WPW syndrome, these drugs are contraindicated. So that's because if you do not know what is the underlying etiology for atrial fibrillation, it's safe to use a drug like amiodarone. Okay, so definitive treatment is the radio frequency ablation of this abnormal atrial tissue. So how do you diagnose WPW syndrome? There's a very short PR interval. And you can see there's a delta wave. Okay, this is called delta. This pattern is a typical for WPW syndrome, the short PR and the delta wave. And now we move to the bundle branch block. There are two types, right bundle branch block and the left bundle branch block. And the left bundle branch block is usually, remember, the etiology is usually the ischemia, and also not only the ischemia, they are having underlying structural cardiac lesion. So if you see a patient with left bundle branch block, it's actually not innocent. So usually left bundle branch block, how to diagnose? They are having the broad QRS complexes, and also they are having the deep S in V1, broad and the deep S in V1. dominant S in V1 with this bit broad, and usually you see a M pattern in V6. Okay, that's how you think and diagnose that the patient is having left bundle branch block. So you can see this is a diagnosis of left bundle branch. You can see that deep S, deep broad S in V1, and also the M pattern is not very characteristic here. And but you see usually you see the tall and the M here as well in the V6, but you can definitely see the deep S, and also it will actually mimic ST elevation in the V1 to V2. Okay, so that is not the ST elevation in my, but this is a left bundle branch block. Okay, the broad QRS as well as the deep S. So this is the left. I told you when the irregular, sometimes the broad complex is a atrial fibrillation associated with left bundle branch block or right bundle branch block. So this is a atrial fibrillation with left bundle branch block. So how do you diagnose? Because the RR interval is, you can see it's irregular. Okay, and but the patient has a deep S and the broad QRS as well. Remember, this is not VT. Okay, so this is not definitely VF. No, so this is not VT because it's a RR interval is irregular. So this is the atrial fibrillation with a left bundle branch block. Similarly, you can get the right bundle branch block with a atrial fibrillation. And now we'll move to the right bundle branch block. Right bundle branch block that you diagnose, there's a actually R pattern is there. You can see the R, S, and the another R. Okay, so that is RSR pattern in the usually you see in the V1 and the V2. And with that you get the T inversions as well, the V1 to V3. That is normal. Okay, and also you get the slurred S in V6. Okay, this is the RSR pattern, the small r, and the second R is tall. Okay, broad. These are both actually the QRS is a wider, broad complex, and the V that you get the deep slurred S in the V6. That's how you diagnose the right bundle branch block. Okay, this is the right bundle R in V1. Okay, so you use in left bundle, you saw the deep S in V1. Here, right bundle, you see the tall R in V1. Okay, and now we'll move to hyper and hypokalemia. So we'll see some ECGs of the hypokalemia and as well as hyperkalemia. So what are the features of hypokalemia? That you see usually the PR interval could be prolonged, and the ST segment could be there's a depression, and also the T could get flattened, and the presence of U waves is usually very significant when there's a hypokalemia. Okay, when it is less than 2.7 that you see these changes. So this is about that ST depressions and also the presence of U waves. Okay, and when there's a worsening of hypokalemia, that the patient usually get this, they can go into supraventricular and the ventricular ectopics are common. So if the patient is having these things, you have to suspect actually electrolyte imbalances. I told you earlier also, when there's a any kind of a ventricular ectopics also, that you have to suspect. Okay, so and the supraventricular tachyarrhythmias, they can go into the atrial fibrillation, flutter, and the other atrial tachycardias as well. Sometimes they can go into the ventricular tachycardias as well. TT and the torsades spontis as well. And so in this ECG, you can see this hypokalemic ECG. There's a significant ST depression and also the presence of U waves. Okay. And this is the U waves. So this, if you see something like this, actually that is a diffusely you see in all the leads. Don't diagnose any ischemia and these things, because ischemia is not present in all the leads. So if you see something like that, you have to suspect that the patient is having hypokalemia. So this is the actually patient with hypokalemia with the presence of U waves, then going into the torsades. Okay, as a complication. Now we'll move to the hypokalemia. Hyperkalemia. So in the hyperkalemic thing that you see the depending on the level of the potassium, that you will see the ECG changes. Initially with the when it is 5.5 to 6.5, you will see the tall, the peak T waves. Okay, when it is above 6.5, that the P's get actually widen and the flatten, and the P's get prolonged. Then ECG that you see something like that. Okay, with the PR could be prolonged, and after that when it is above 7, you will get a lot of the conduction abnormalities, and the patient they will get into actual bradycardic. Okay, there could be again the AV blocks, and the patient can get into the bundle branch block, the fascicular blocks. Those are all the things that you can in the also the QRS complex become the very bizarre. And when it is above 9, actually they go into the VF and the asystole. Actually, it's not compatible with life if they have this kind of potassium. This is actually, you can see the significant bradycardia and also the tall T's as well. Okay, you cannot see P's are getting actually flattened. This is again a ECG with the hyperkalemia. And you can see again the broad QRS, again the very tall T's, and also this is of course this is called sine wave as well, and this is somewhat tinted T waves. Okay, and this is again you can see this typical very severe hyperkalemic ECG. This is again a similar one. Okay, so if you see something like this, rather than diagnosis ischemia, that this is the hyperkalemic ECG. Okay, this is again the sine wave. These are all the hyperkalemic ECG. You can see how bizarre the ECGs are. So hypocalcemia, only one ECG I'm going to show. Remember, you will get the prolonged QT with the hypocalcemia. So after thyroidectomy, that's very common. Or if the patient you have not replaced with calcium levels, so patients can get the complications. There is a prolonged QT. Okay, so learn about what is the normal Q and how to calculate the QT interval as well. There's a equation for that. So we'll discuss some ECGs of acute coronary syndrome. So I'm going to talk only about the ST elevations. So as now it's almost 1.5 hours. Okay, so we'll just think this is actually normal ECG, and then with when there's a when the patient, the first thing is the acute ischemia is with the start after about few hours that the patient get the tall T waves. You call it a hyperacute T's. Okay, that's a very early thing. If you see a patient is a typical ischemic pain, the tall T's that you have to suspect and you have to repeat serial ECGs, because in the subsequent ECGs, in the after a few hours, patient should develop ST elevations. Okay, just ignore these. What is the first day done? Usually after 2 or 3 hours later, patient will develop ST segment, ST elevations. Okay, the small Q is there in typical ST elevations. And after about 12 hours later, that the Qs become little deepening and the T's are actually getting inverted. So if you see a ECG with a ST segment also coming down a little, not taller than this, and definitely it's after 12 hours. So by that time, so if you see this ECG, you have to give the either a primary PCI or else thrombolytics. So if you see these are getting inverted, that you know that the patient this is a late presentation. Sometimes if you see this ECG and you have not repeated the ECG, you are doing the ECG in the next day only. So you might see something like this. Patient has come early to the hospital, but you have diagnosed the ST elevation MI later. So it's not the late presentation, but it's the late diagnosis. Okay. So because of that, very important, if you see the hyperacute T's, you have to repeat the ECGs hourly until you see the ST elevation, and you have to quickly do the primary PCIO. You have to give the thrombolytics. So in the later, after about 2-3 days, and the ST segment has come down to the baseline, and then there will be deep T inversions. And several weeks later, the T's are getting normalized. Some patients actually, it takes more than that as well. And those are actually the ST and the T's are that you see in the typical ST elevation MI. So the anatomic groups on the ECG leads are very, very important when the diagnosis of the acute MI. So for that, of course, you should know what are the leads. So usually we group ECGs, ECG leads. So you know, leads 2, 3, and AVF, you call as the inferior leads. So if you something here that you in these 3 leads, you call as a inferior MI. This leads 1, AVL, V5, V6, you call as a lateral leads, because these are the lateral side of the ventricle. Okay, because of that, you call this a lateral leads. 1, AVL, V4, V5, and the V6. If it is 1 AVL only, you call this a high lateral. 1 AVL only, high lateral. And leads V1, V2, it's you call is a septal leads. And V3, V4 is anterior leads. Okay, so depending on these things, we diagnose and we name the ECGs, MIs, by looking at the ECG. So now you all have to tell what is the diagnosis. Okay, so you have to, when you are given this ECG, first thing that you have to read the ECG, you have to see whether the patient is in sinus rhythm or not. Is this patient is in sinus rhythm or not? Anyone?
Thanks. Thanks.
Sinus rhythm, ne? You can see the P, Q, R, S, and also the T's are of course not very clear, but it's a P is there, Q, R, S is there, T is here. No? So it's a sinus rhythm. So what are the abnormalities that you see in this ECG?
Bradycardia.
Yeah, one thing is a bradycardia, very good. You can see the patient is having, you have to look at the rate. You can count the things. So usually it's a 50, the rate. What else that you can see? I can't see your faces. I can. Yeah, in ST elevations in
2, 3 AVA.
Yeah, very good. There you can see the ST elevations in lead 2, 3, and AVF. So one diagnosis that you know, what is it?
Inferior STEMI.
You can say acute mono inferior ST elevation MI. Okay. What else that you can see here?
Reciprocal
Yeah,
changes.
there are reciprocal. There are ST depressions in the lead 1 and also the AVL and also V4. V5, V6 not very clear, but usually you will have in those leads as well. And why the reciprocals are there? Because there's a mirror image of the inferior leads. Okay. So if you see this reciprocal changes with the ST elevation, you know this is very acute MI. You have to give the primary PCI or the thrombolytics. Other than this patient is having what? What is this? Yeah, right branch block also there is in this ECGs. Oh, what is the diagnosis here? You can see sinus rhythm. Why that patient has a bradycardia? So it's a complication of the right coronary artery, you know. They can get the bradycardia as well because it supplies the SA node and the AV node also. What you can see here. Anyone you can guess? It's not difficult. You can see, ST elevations in lead 2, 3 and AVF. Yes or no?
Yes, madam.
Yes. What else is there? You can see the ST depressions in the V1, V2, V3. What is this? So if there are ST depressions in V1 to V3 along with the inferior MI, this is the posterior. Okay. How to diagnose posterior MI? So if you can suspect this when there are ST depressions, so if you can diagnose a posterior MI, but when there are ST depressions in V1 to V3, but to confirm that, you have to place the leads V7 to V9. And if you do those things, ECG, there will be ST elevations in those leads. Okay. So the posterior leads are the mirror image in V1 to V3 neither. So because of that, you see reciprocal changes in these leads. Okay, those are the mirror image of the posterior leads. Usually in the routine ECG, we don't do the V7 to E9, no. But you can confirm it by placing those ECG leads and taking the ECG. So there will be ST elevations there, V7 to E9. But for those three, the mirror image is the V1 to E3. So you will see the ST depressions there. So this patient is having acute inferior as well as the posterior MI. Okay? Yes? Are there any heart blocks? No, there are no heart blocks. Okay? I think there's a SLMA lecture is there at 7 o'clock, no?
Yes, madam.
I think you all have to join that one. Shall we wind up this one? I'll do rest later. Okay?
Okay, madam.
I think you should, you all are joining that one, no? Did you all register? Yes or no?
Yes, madam.
I think I will stop this one and I'll do the rest later. Okay. Right. Thank
Okay.
you. You all can
Okay,
leave and
madam.
join that one.
Thank you very much, madam.
Right. Okay. Bye.